6 years, I think, since I've been at the conference, and I always love coming to these meetings in particular, and I love the audience and the discussion at this meeting in particular, so I'm really grateful to be here again. So I'm going to start with a high-level view of things that I hope will make you feel good, and then we'll move to some things that will make us all feel uncomfortable and anxious, the challenges, and then we'll circle down to some nitty-gritty, some simple tips and approaches around prescribing, and approaches that I hope you'll see, as Aaron said, as relatively straightforward to use as you go back to your practices and clinics on Monday. Mostly, I hope that by the end you'll feel excited about the opportunities of these small changes that you can make in your day-to-day practice that will make a huge difference for patients. So I think it's appropriate at the Therapeutics Initiative meeting to stand back and think about what we mean by therapeutic as it relates to day-to-day primary care. And this first meaning definition you see here is the one we tend to shortcut to first, but before we go there, I'm going to touch on the others. This image on the right is the rod of Asclepius, and it's the symbol of medicine, and it represents the integration of the Hippocratic school of medicine, the approach to care that's objectively scientific, the things that medicine does to people, with the Asclepian school, which embraces the healing of the person from within, the subjectively humanistic. And you might say that this integration actually represents wise primary care generalism. So what's the therapeutic effect size of this wise primary care generalism? So I'm going to ask you to raise your hands quickly, as we don't have time for an online poll. If the supply of family physicians is increased by 10 per 100,000 people, how many less people do you think would die each year? Do you think 30? Who thinks 30? Some? 20? 10? 1. So the people who pick 30 are right. There is a dose response for this relationship as well. The more primary care physicians there are, the more mortality reduces, and that's strong evidence for causality. This association doesn't hold for specialist services or hospitals. Policymakers take note. Is this about access to evidence care? As long as care is provided, does it matter who does it? So what do you think? If you've been with the same primary care clinician for 15 years, how much do you think this changes your risk of death? So continuity, 0? Not at all? 5%? 10%? Some at 10? 25? Yep, you're getting the idea. 25%. Compared to less than 1 year. And this study from Norway of the whole country, over 5 million people, showed that the longer you have been with your family doc, the more likely you are to live longer. Isn't that extraordinary? 25%. Show me a pill that does this for the population. And staying out of hospital, even more. And you're about just under a third less likely to need out-of-hours services. Again, you can see in the image there the clear dose response, clear evidence of the causal relationship, more powerful than any medicine. We've just completed a systematic review of measures of primary care continuity and are wading through several thousand papers. What's even more striking than ever is that the continuous primary care that you provide every day to patients really matters. And it doesn't matter how you measure it or what outcome you choose, across the breadth of primary care, continuity matters. And interestingly, in a study by Chan and others, among patients with hypertension or diabetes, continuity reduced all of these things, yet there was little to no change in the usual targets, intermediate outcomes such as blood pressure or HbA1c. So it's nuanced and complex. It's not just what gets done, but who does it. And this includes rational prescribing. And this occurs because continuity significantly increases appropriate prescribing and decreases inappropriate prescribing. And where that really matters is here. Our biggest therapeutic challenge in primary care, but also offers us one of the biggest opportunities we have to improve clinical care for adults in the next 20 years. One of the issues we have as clinicians is the kind of adverse effects that our patients suffer from have shifted, and they're a lot less visible than the ones on the left that I learned about in medical school. And often in older adults, it represents not a single drug side effect, but a cumulative burden of side effects that are really easy to miss. And this is a problem for the health system Here's uncomfortable fact number one. In the EU, where we have the best data, more people die of adverse drug effects every year than die of colon cancer or breast cancer or lung cancer. It's the equivalent of more than 2 jumbo jets every day crashing and killing everybody on board. If this was an airline, would you fly on it? But our patients do every day. If this was an airline, the fleet would be grounded until the system issues were fixed. There are screening programs in place for these cancers, yet this cause of death and illness is largely invisible in the focus on epidemics of disease and the need to treat risk factors. And it's not just a problem for the health system, but for the planet, as you can see here. Canada has the dishonour of being the 4th highest per capita greenhouse gas emitter from healthcare in the world. It's equivalent to our emissions from air transport and from truck transport. And you can see here that drugs are the highest contributor to these emissions, even higher than hospitals. And in terms of interventions, you can see from the peach on the bottom right that reducing drug use is the least costly, it actually saves costs, and the most effective thing that we can do. To give you an idea of the impact of small changes, this is the effect of just reducing medication use by just 5%, 1 in 20 drugs. So that's translated to primary care for 5 patients on 5 medicines, just reducing one of those drugs. And you can see the enormous impact that has on emissions and costs. But rather than deprescribing, I like to think of this as rational primary care prescribing, that is not doing or undoing prescribing that is unnecessary, unwanted, or unhelpful. And it's actually an old idea with a really familiar name. Evidence-based medicine. And 6 years ago, we talked about how guidelines have created a kind of sacred monster that makes polypharmacy inevitable. And I'm going to take us a step further today. This lovely original EBM model that's so familiar, valued this therapeutic effect of clinicians in translating the partial statistical lives of trial participants into the real lives of patients with wisdom, restraint, and expertise. But this model has been captured by the linear accountability and market theory in a way that was never intended by its creators, used as a tool for measurement, reductionism, and targets. And this broke open Dave Sackett's original idea of EBM. In the current era, the evidence becomes disconnected from the patient's clinical state, their priorities and preferences, with the idea of care as standardised to doing what the research says for everybody, outcomes will be better for all. And the integrator, clinical expertise and continuity of relationship is completely lost, with the assumption that it doesn't matter who does it, as long as it gets done. And we're all familiar with this end result. If we take a typical 70-year-old and give her what a typical 70-year-old has, 5 conditions, doesn't matter which ones we choose, this is the end result. So what looks like measurably good care is meaningfully worse for the individual. And now one of the problems is that we all, and me included, suffer from a kind of therapeutic positivism. Studies show that we and patients tend to overestimate the efficacy of the things that we're doing and think in terms of most of the patients that we're giving a prescription to likely benefiting, which is not true, because for most patients to benefit from a medicine, the NNT must be 2. Our problem is we can't tell which patients will benefit. Whereas we tend to think of side effects, and looking at this language here, as potential or possible, and both we and patients tend to imagine or hope perhaps that the harms are rare and will happen to somebody else. We also tend to think of the harms of polypharmacy in terms of frail older adults. So how do these possibilities translate into the real lives of patients? We did a recent RCT of a clinical pathway that was really focused on reducing the harms of polypharmacy called TAPER, and as part of that we developed these screens for these potential harms and cumulative risks. Now, the Canadian longitudinal study on ageing is a cohort of over 30,000 older adults across Canada, community dwelling, who have this huge array regularly of direct functional measures, as well as detailed recording of their medications and their conditions. And so we just finished some work in parallel to the trial, applying these screens to this cohort and relating them to these direct functional effects on patients. And these next data are hot off the press. I only got them a week ago. You're the first to see them, and they're unpublished, so please don't share them yet, especially on social media. We looked at the number of different types of potential adverse effect screens that were flagged as positive, including things like anticholinergic burden, drugs needing dose reduction and CKD, drugs causing hypotension, because you know that commonly lands our patients in hospital, drugs that prolong the QT interval, drugs that increase the serotonin burden, and potentially inappropriate medicines in older adults. And the reason that I wanted to share these data with you is the effects here are startling. We controlled for lots of things, which we're not usually able to control for, particularly those things and morbidities that are associated with the outcomes themselves. We really wanted to clarify and crystallise the direct effect of multiple medicines beyond the morbidities themselves. And you can see here in these odds ratios and confidence intervals a strong and clear dose-response association with poorer physical function. This is it's rare for us to see an effect of this size, particularly when it relates to direct functional measures on the patient. And this particular outcome is important because when we asked patients in our trial what mattered most to them, the thing that they told us was that physical function and mobility were the most important goals for them to have their medicine support. We saw similar effects in cognitive function and also in psychological effects. And you can see here that the more potential screens that flag, the higher your risk of current measured depression. And this effect of drugs on mood is supported by another line of evidence. This study was done in a really large population data set in the US. And this showed that firstly, 1 in 3 adults in the US take a drug that can cause depression as a side effect. It also showed that the more medications you're on that can cause this side effect, the more likely you are to have a subsequent diagnosis of depression. And this is a really important and real effect, reaching 15% of patients on 3 or more of these meds. And these are not rare medications. The included medications are ones that we commonly use, like selective beta blockers, PPIs, analgesics like naproxen and hydrocodone, anxiolytics, sedatives, and hypnotics. So what we're seeing here is real. And here's the most important association when we think of the purpose of the clinical care that we provide every day. You can see here that the reduction is satisfaction with life. And you may think that these are frail, multimorbid, older adults in these high screen groups, but this cohort is a relatively well-researched volunteer cohort of community dwelling people who are age 45 and older. These are our patients. And here is just what 3 of our most commonly used drugs in Canada resulted in terms of lighting up these screens. So here's a PPI, an SSRI, and a beta blocker. So this is pretty confronting. This is neither safe nor sound for our patients. How do we address this? Well, the very first part of the approach is to find ways of explaining to patients how seemingly good medicines with kind of good evidence for individual conditions taken together may be a bad idea. And I make no apologies for reusing the next metaphor because I find it the most effective way to explain to patients how good medicines can be bad for you. So I'm sharing it in the hope that you find it useful as well. So it's a little like music. If we listen to some Bach or some Miles Davis, some Leonard Cohen, the Four Tops, or some Bruce Springsteen. You can tell how old I am by what I've chosen. Played on their own, they sound good and they make us feel good. Well, what happens when we play one and then add another and add another and another? And another. They become a cacophony. I can see you putting your fingers in your ears. They make us feel bad. And this is what it's like for the patient on polypharmacy. So Will Durant is an American philosopher and historian, and he translated a statement of Aristotle's in his Nicomachean Ethics book as this: "We are what we repeatedly do. Excellence, then, is not an act, but a habit." So how do we start in practice? How do we change our habits? Sometimes thinking about polypharmacy and addressing it is a bit like this. It's feeling like it's a big wave that we have to surf all at once. And this is the tips and tricks section. So some habits that you can try that with a few relatively simple steps can make a huge difference. It doesn't need to be complex because the biggest risk for these negative outcomes is just the pure number of drugs people are taking. So just reducing that number by 1 is a big win. So I hope you see here some things you can say, yes, I can start this on Monday. And we're going to look first at 4 drugs to notice. And there's great evidence in the TI resources about many drugs that you can access in the wealth of reports and webinars, but I've chosen these ones as examples today for 3 reasons. First, because they're the most used in Canada. Second, at the bottom of the slide, just reminding you of the risks that they flag. And thirdly, because the data shows us that there is substantial legacy prescribing of them all, so a great opportunity for system change. What are legacy drugs? They were drugs that are appropriate when we start them and when prescribed for an intermediate course length, longer than antibiotics, say, but they're never intended to be a life sentence. They assume legacy status when we don't appropriately discontinue them after the course is finished. So the first part of the arrow is the recommended length, and then beyond that point, the prescription becomes legacy. And we've studied now in 2 countries, Canada and New Zealand just this year, taken it as examples of drug classes for physical symptoms, psychological symptoms, and a risk factor. And we were pretty generous with our legacy prescribing periods. We used 15 months or longer for PPIs and SSRIs and 5.5 years or longer for bisphosphonates. And you can see here that if you started on a PPI or an SSRI, you have a 50-50 chance of it being prescribed for longer than the recommended course. And 1 in 10 people prescribed a bisphosphonate, again, have a course length that's longer than what's recommended. And this is probably an underestimate given the length of time we're actually able to study this. And you can see from the column on the right-hand side, and this is the Canadian study figures, that this is not a little bit of slippage. This is a lot. It's nearly 5 years. And 60% of these are still currently being actively prescribed the medicines. Huge opportunity for improving care. It's not a bad prescriber issue. It's a system issue that needs a system focus. We have great systems for starting, but not good systems for stopping when we need to. How you do this in your practice, what works for you will differ. What I do is I engage with a team, the pharmacist and the patient, and I set the expectations of the patient at the beginning of what the course length is and when we'll taper off in the spring, next fall. I write it on the prescription so that the pharmacist and any locum or other doc can see what the plan was. And I engage a pharmacist by sending a tapering prescription when we're about to stop so they can support the patient as well. So we've talked about those 3 drugs to notice, but here's an emerging new kid on the block for legacy prescribing. I can't give you the figures because there are multiple overlapping indications for beta blockers, selective beta blockers. However, we can see this is starting to emerge as a common legacy medication, in part because of the more detailed evidence we have now and advances in management of acute MI. We've already had a stimulus to review beta blockers in our patients as they reach 60 because of this evidence from a systematic review that I've summarised on the left. It doesn't do our older adult patients any good in terms of cardiovascular outcomes that we're trying to prevent. But there's other new review evidence that suggests another situation where we need to review beta blocker prescribing and make sure there are no legacy prescriptions. So there's newer evidence for the effectiveness of beta blockers after acute MI. And it's thought that the changing context of management of acute MI, rapid revascularisation and other things, has changed the effectiveness and the place of this management. So older recommendations, you'll remember, were for about 3 years. And many patients still have legacy prescriptions from that because we don't start them. And sometimes it's a bit unclear from the discharge note about why they were started and that they ought to be stopped. So often they were continued beyond that 3 years. More recently, recommendations have moved to a year in the light of newer evidence. So let's look at that newer evidence. So this is a trial of a cohort study, observational, of beta blockers after MI that came out last year. It was a big study, nationwide, and it looked and followed the 3/4 of patients that had a beta blocker after their MI and the year after, and the just under a quarter that didn't. And they found that there was no difference in risk of the kind of composite cardiovascular outcome that we'd be interested in, death and new MI. And there was a decent follow-up. And then following this was a stronger methodological study, a randomised trial of selective beta blockers after acute MI. Again, those with a good left ventricular ejection fraction, and a good sample size and a good duration of follow-up. And once again, you can see there's really no effect on the composite outcome of the things that matter to us in patients, all-cause mortality and new MI. And you can see hazard ratio is close to 1 and the confidence interval is fairly well balanced around 1. So you think this is all sorted, we know what to do now, but into the abyss, oh no, in the same journal, in the same year, this year, is another study, the ABYSS study, which looked at patients with a slightly lower threshold for left ventricular ejection fraction. Again, a reasonable sample size. And they looked at stopping beta blockers a year after acute MI. And this suggested that stopping at a year did have a difference in the composite outcome. But if we look at this composite outcome and what makes it up, and look at what this 2.8% difference actually was, we don't need to feel quite so alarmed. Because if you look here at the outcomes that really matter to us in patients, death, MI and stroke, there was absolutely no shift. So there's no difference in whether you continue or stop beta blockers. And the whole primary outcome was driven by one component, which is hospitalisation for cardiovascular reason. And this was mostly referral for angiography. And this was an open trial, so the clinicians who were referring knew that the beta blockers had been stopped. So you could see immediately how this would introduce clinical bias, and this is probably what we're seeing here. So we don't need to feel dismayed or alarmed. In patients with normal left ventricular ejection fraction and no other indication for use, these drugs can be safely stopped conservatively after a year, and more evidence may come out to suggest earlier. As always, taper. Warn about the sense of rebound increase in heart rate, which can feel a bit like anxiety, and also any masked chest pain that might emerge, just in case there's angina that's been being masked. So moving to the next example of the drug to notice, SSRIs. I can't do a talk without mentioning SSRIs. Use has grown steadily, as you can see, in all countries across the world over the last 2 decades, to the extent that if you walk out the door here, 1 in 10 of the adults walking around Vancouver will be currently taking an SSRI, which is a John McEnroe, you cannot be serious piece of data. And most of this growth is not from starting more patients on them, it's that people are going on them and staying on them long term, so legacy prescribing. And you can see in the data on this slide here, the legacy prescribing, that's a really big opportunity to reduce low value care. And there are 2 issues at play here. One is the legacy system issue, and you can see here that even in that group of patients who have some indication for long-term use, this legacy length is way beyond that. But also what's unhelpful is the recommendations for long-term use are really vague and unclear and not evidence-based. Things like more than 3 episodes, comorbidities, ongoing stresses or patient preference. Now, I can bet that there's not a person in this room that hasn't had some sort of ongoing stressor in the last year. It's important also to think about the natural history of depression and the role of treatment. So medications don't cure depression. It's not like insulin that as soon as you stop it, the diabetes bounces back. How they work is they help alleviate the depression symptoms while the episode is present. And as we know that whether we give medication or not, it resolves at 6 months. So it simply covers those symptoms until the episode naturally remits. But when patients then stay on SSRIs after the depression episode is settled, we may all think that they're well because of the medications, but it's actually just because the episode has resolved. Now, I'm just going to touch on this very lightly because both Mark Horowitz and I have covered the evidence for SSRIs, the evidence for how and when to stop in 2 recent TI webinars, and the QR codes are here. So just some brief summary points. The early discontinuation trials really overstated the benefit of long-term SSRIs because they were in more severe, often hospitalised patients. They didn't include primary care patients. And these patients were often on really high doses of SSRIs and were often stopped suddenly without taper and without recognition that the discontinuation symptoms confounded the influence of withdrawal symptoms on the outcomes. So the benefit was really overestimated. We now have some information from primary care trials, and my conflict of interest is I was involved in both, but 7 out of 8 patients in these trials experienced no benefit from the maintenance treatment over a period of 18 months. And the difference, this absolute risk difference, is interestingly similar to the population annual incidence rate for depression itself. At least half can be stopped without any recurrence or any significant withdrawal, or the patient simply wanting to go back on. And the number needed to trial to be able to stop one person successfully is 2 in this case. And outlined in the webinars, there are some really careful approaches now for successful stopping in those who do have significant withdrawal. So trialling stopping is both sound and safe. There was no difference in outcomes or serious adverse events in any of those patients in the arm who trialled stopping, and some suggesting that their social functioning was in fact better. Why stop? Here are the harms of long-term SSRIs, and they're harms of significance to patients. To touch on just a few, the bleeding risk. The bleeding risk, we're really familiar with the NSAID bleeding risk. Well, the bleeding risk from SSRIs is not too far from that, and it's mediated by the effect on serotonin and platelets, so it's all kinds of bleeding, cerebrovascular, GI, post-surgical bleeding needing transfusion. Now, if you're a patient that needs acute or even planned surgery, it's usually too late by that time to taper off the SSRI, so the patient is stuck with this risk. So a really good reason to stop before you get into the legacy prescribing zone. Falls risk is actually the same as tricyclics in older adults, yet we tend to shortcut to thinking about tricyclics as dangerous. And sleep disturbance, really important concern to adult patients, right? Total sleep time is reduced, awakenings are increased, and sleep latency is decreased. So lots of reasons to rock the boat and not prescribe beyond the recommended course length. When and how to stop SSRIs are a whole talk in itself, but some summary points from the 2 webinars are these. Let patients control the rate. Some, especially if they've been on for longer, may need months or even years to be able to taper, and that's the last part of the taper that may need to be a lot slower. It's the hardest. You can see in this dose response image on the right how serotonin receptor occupancy just crashes as you get to these lower doses. But there are ways now to manage these small steps successfully, and see the webinars for all you need to know about how to successfully manage this. So moving to our next drug to notice, a study spanning 10 years up to 2010 in seniors in Ontario showed that bisphosphonate prescribing for women has doubled over this 10-year period, moving from 11 to 27%. And a recent TI letter, the QR code is there, outlines the evidence in detail, or rather not, for population screening and the benefits of medication, which I encourage you to read. It's about starting. But in addition, we found that 1 in 10 patients receive these for beyond the period of evidence for any impact. Bisphosphonates, again, have side effects that really affect quality of life, and we know that many patients actually stop these drugs themselves. The Burden study in 2012 showed that less than half of patients persist with bisphosphonates for 2 years, and most have 2 or more gaps in therapy that indicate both ambivalence and side effects. Some of these are uncommon, but when they happen, they're really devastating. So you want to be sure that the benefit is worth it for the patient and they understand the magnitude of that. Being haunted by prescribing regret when in retrospect the medication was low value or legacy is awful for both us and for patients. Atypical fractures of the femur are rare, but this risk substantially increases with increasing duration into this legacy length. So this goes from 16 per 100,000 people treated with bisphosphonates for 5 years to 113 per year per 100,000 people treated with bisphosphonates for 10. Stopping treatment seems to lead to a reduction in this risk. There's a Swedish study that shows that the risk of atypical femoral fracture declines by about 70% a year after you stop. When and why to consider discontinuing? Beyond the evidence for whether or when to actually start, well, bisphosphonates have this lovely effect. After being stopped, the drug remains in the bone and released into the body. We know that even in the longest follow-up there has been after stopping, after about 3 to 5 years of use, bone mineral density never decreases to the level it was at which you started. And you can see here there are recommendations here that are based on this effect that take into account patients who do have a very, very low bone mineral density and perhaps are on osteoporotic inducing medicines, or they've had previous fractures and have a high fracture risk, that they may have some benefit from extended treatment. So moving to our final drug of interest, PPIs, and I know you've heard this all before, there's tons of clear, choosing wisely, evidence-based recommendations for not continuing beyond a few months. But we do continue. And again, the mean duration of legacy prescription is long. And yes, there are some reasons in all of these drugs for some patients to benefit from long-term prescription, but these figures are way beyond what we would expect from that. So you can see, again, in these two pieces of data on the slide here, the system issue that's a really big opportunity to both reduce low-value care and increase safety for patients. Why? Why stop? Well, there are important side effects of PPIs, and these are just some. And if you look closely at these, you can see the legacy prescribing dilemma, because PPIs are really effective in stopping dyspepsia in the short term. They have one of the lowest NNTs for this of any current medicine. And that's why we use them and why patients appreciate them. But you can see here that the adverse effects are pretty much all of the kind that accumulate over time, and that we don't necessarily link to the drug, but are really important to patients' quality of life. And a few years ago, I met with a cardiologist who was retired, but who had been a teacher of mine, who came to a talk like this, whose life had been blighted by illness and regret after he developed severe interstitial nephritis from long-standing PPI use that in retrospect was of low value. So just briefly covering the how of stopping. Studies show that we can discontinue if we try between 14 and 86% without loss of symptom control, particularly if we put in non-pharmacological methods while the PPI has bought us time. Tapering seems to result in more effective stopping, but there's no evidence for any particular pattern. So let the patient guide the taper. And there are various goals that will have important benefits for patients. The approach that I find the most successful is tapering to a stop to the extent you can with the preparations available, and then switching to PRN, so you give the patient control. And if they understand the reasons, the harms that you're trying to avoid, and you give them control, then I find that is usually really successful. If they know they've got them there to use in the cupboard if things get really bad, then it really helps them to reduce, and they're usually very pleased with being able to stop completely. I warn them that symptoms will bounce around a bit as the body gets used to not having the acid suppressed, so the body figures out how much acid it should be produced, but that will settle if they just push through. And there are some great patient resources here that can really support you and patients. So, moving now from some drugs we can notice as a habit that could have a really big impact to some process habits that we can change in our practice. So this systematic review by a student of Amy Page, who's an Australian pharmacist who's doing some really great research in this area. A systematic review shows two things. It suggests that deprescribing can reduce mortality, but it suggests we need to start early, that the negative effects of polypharmacy may be embedded once patients reach much older age. And the second thing it suggests is that a person-focused approach is key to success, which sounds good, but how do we actually practically approach this in day-to-day practice? So Lucius Seneca was a Stoic philosopher and writer, and incidentally an advisor to Nero, which didn't go well for either of them. But his letters are well worth reading. And he wrote this piercing reflection on quality of life. The part of life we really live is small, for the rest of existence is not life, but merely time. And RCTs often talk about quality of life and give some insight into the impacts of the population effects of medication use. But importantly, these objective measures are not relevant to us in the individual consultation. Here, quality of life is subjective rather than objective. Quality of life is individual and personalised. What a life worth living is for an individual, the part of life they will really live, and how best to use medicines to support it. It's important to actively note that it's not our view of quality of life that's important here, but it's that particular patient's. And this may be a different perspective to our medical one, and that can be challenging for us. But how do we do this? So these energetic young people searched the literature to see if there were any tools, and they found pretty much nothing. So we asked patient groups about their experiences and how we might go about this. And what they told us is that we're not actually in the habit of asking them, which I found pretty challenging. They told us that they often just experiment on their own and stop drugs without talking about it with us, and we know this. And we asked them what worked when these conversations went well. And they said when they were treated as experts in their priorities and preferences for treatments, as well as the medicine's effects and side effects on them, and when they perceive us to be patient-centred in our approach, things went well. Explicitly asking is at the core of evidence-based medicine. Patients are afraid to ask, but they want to be asked, put much more eloquently by Tennessee Williams. I don't ask for your pity, but just for your understanding. Not even that, no. Just for some recognition of me in you and the enemy time in us all. Patients told us that understanding what they need from medicines is embedded in the asking of these kinds of questions. Questions about what functional and symptom issues are important to them, what their experience and opinion of these effects and side effects of medicines is, what their priorities are for current symptom treatment versus treatment for prevention of future illness. And we tried this out. We gave these questions to patients and we asked them to reflect and respond before they saw us, the pharmacist or the family doctor, so we could see them prior to the consultation. Try this. You will be amazed at the conversation doors that it opens and how simple and obvious it becomes how to prioritise medicines and prescribe rationally for that patient. So did this make any difference to what happened? As I said, and I just remember the CLSA data slide, physical function and mobility were overwhelmingly the most commonly described. And what we found was that when we asked these questions, 44%, nearly half of the subsequent medication recommendations mapped directly onto a patient goal or priority or an unwanted medication. The rest were just based on evidence alone. If these priorities are embedded in patient records across the system and medication decisions we make map onto them, no target or guideline can ever trump that as the most excellent care. Knowing these things makes the next process habit really easy. Dividing the drug list into drugs for symptoms and prevention, we can take an individual focused approach. The beauty of the N=1 trial. And almost all patients support the idea of a drug holiday now and then. In drugs for symptom treatment, the patient can judge the ongoing effectiveness for them. Even just sneaking the dose down can tell us whether that treatment is still working that's why they don't have any symptoms, or in fact their symptoms have disappeared. In preventive treatment, we use patient-informed decision-making based on the evidence to allow them to make the choice they want to make. But we can also determine whether those treatments are still effective. In preventive treatment, we will never know whether the blood pressure is controlled by the medication or whether things have changed, as we know, with body habits and lifestyle and ageing, and the patient is actually no longer hypertensive underneath this. And there's evidence for this, as you can see there, in trials of stopping antihypertensives, but depending on the trial, between 20 and 85% of patients didn't have a rebound increase in their blood pressure. And another study supports this kind of figure. So not offering a trial of dose reduction and an efficacy test from time to time is really depriving our patients. It's also an opportunity to revisit targets, and Wade Thompson did a great TI webinar recently on glycemic control targets. And part of all this, as always, is the process. Prepare, warm the patient up with the rationale and reasoning for why you're doing what you're doing, what your shared goals are in stopping medicines. Engage with other non-drug strategies and family members. Let everybody, including other clinicians in the circle of care, know what you're doing and why. Let the patient know what to expect in terms of these kinds of effects, because this will help you judge after the drug holiday whether the drug is worth it for the patient or not. And monitor, and this is a key part of the process, plan for follow-up, and agree on criteria under which you might restart, because restarting isn't failure, it's just good monitoring. We also worry that if we stop a medicine that something bad will happen. And this is magical thinking on our parts, because the data doesn't support this. There's been no significant difference in adverse events or serious adverse events in any deprescribing trial, either specific drugs or in general. So I'm hoping that this is a smorgasbord of things that you will think, I can try one of these on Monday. Ensure continuity as much as is possible in the current environment of care. Ask the 7 questions. Prioritise patient expertise, what they want and what their experience is. And plan for dose reduction, pause and monitor drug holidays. This is a regular part of assessing ongoing prescription. And think about some system approaches and habits that you can put in place for yourself and for your clinic. So let's see what these are really simple steps, right? We don't need to know a lot about cumulative side effect burdens or calculate them to do these things. And let's look at how this plays out in a patient. So this is a real patient. This is Catherine, who was 70 and on 10 medicines. The first thing we did was we stopped her 3 legacy prescribing medications, and she felt better already. The second thing we did was we looked at unnecessary or unwanted prescribing. When we looked back at the notes, we found that, in fact, she didn't have a cardiac event of any sort 5 years ago. The drugs had just been started in the emergency department until the results of the investigations came back, and they showed that her chest pain wasn't cardiac and she hasn't had anything since. We stopped the atorvastatin because her cardiovascular risk, we couldn't really calculate it reliably anyway at age 70, but she didn't actually want prevention. The next thing we did was we paused and monitored 2 drugs. One for symptoms, which was the oxybutynin she'd been started on, and one that was for treatment of risk factor, so an antihypertensive. And we found, she said that really stopping the oxybutynin didn't make that much difference. And in fact, she thought that stopping the diuretic had made a substantial difference, particularly in the mornings for her. And we found that after a year of monitoring, she had no rebound, her blood pressure remained normal. So she was left on these 3 drugs. And we've kind of switched to more acetaminophen and just PRN naproxen. So in doing these really simple things, we didn't need complex pharmacological knowledge. Without even having to think about it, these have had huge collateral benefits. We've reduced 5 drugs that can cause insomnia as a side effect, allowing us to revisit the conversation about trazodone on this basis. We've reduced her serotonergic burden. We reduced her falls risk substantially, and we reduced her bleeding risk. Most importantly, and I said this is a real patient, she's now gone from looking a bit grey to looking pink. She bought herself an e-bike. She bikes for at least an hour a day. She has a new partner, and she's living her best life. And we've all had patients like this, right? It's so satisfying. So rational approaches to prescribing in primary care offer a huge opportunity for prevention. Better for all of us, better for the system, and better for the planet. The quality of life for the patient with polypharmacy is exquisitely dependent on the quality of our decisions, the decisions we make with patients. Aristotle astutely observed that quality is a habit, and essential habits in our clinical practice to support rational prescribing start with operationalising and seeking the patient's perspective on their medicines, what quality of life and ageing well will mean for them. And they include habits that will prevent legacy prescribing, which is unnecessary and unhelpful, and reassess ongoing efficacy and dose just as a matter of course. These decisions that we make in the best interests of our patients may run counter to the algorithmic measures of quality care for prescribers and pharmacists, which are almost exclusively single disease-based measures of what the patient ought to be on. To make these decisions, to optimise medicines that are aligned with the patient's goals, and to maximise their quality of life, and not take the safe route of following guidelines, requires, as Aaron says, clinical courage and a firm grip on the evidence. Clinical courage is a fundamental responsibility of the professional role, and it is the core of evidence-based medicine. So, thank you for your attention and your time, and I really hope you at least find one useful thing that you can use on Monday morning.
Thank you so much, Dee. That was wonderful. I hope you all found it as interesting as I did. We have a few minutes for questions. There's some online, but I'll start with the room. How about you?
It could be helpful. Obviously, I'm going to say the ideal is to have a family physician, but we know that demand exceeds supply, and as family physicians are retiring, there's more and more of this, and they land up in the ED for their repeat prescriptions. And so, yeah, I think that could be a useful thing. The problem is it's, often been suggested that we could set up specialist deprescribing clinics, but there aren't enough experts in deprescribing to go around because it's a huge problem. So I think that would be really useful in the short term, but in the long term, we have to persuade policymakers to pay for more primary care physicians. So yeah, I think that's a great idea. But figuring out how you're going to do the follow-up around that, so you need to have not just the sort of in the moment consultation, but some sort of arrangement for sort of follow-up during that tapering process.
Great, thank you. Michael, I'll give you.
So elderly, beta blockers. So hypertensive, older person, and if they're already on the three most appropriate, ACE plus thiazide-like diuretic plus calcium blocker, and their hypertension's still not anywhere near your target. So when you showed data like worse outcomes, but that's not compared to placebo, it's compared to the other more effective meds. So I would take that to mean it's not as beneficial rather than it's harmful. So persons on three meds, should we say don't add on a beta blocker, go to a more esoteric, rarely used class of antihypertensive?
It's a tricky question because there's a slight benefit over placebo, but it's really compared with the other, both alpha blockers and beta blockers compared with the other agents are really inferior. So I guess the approach I would take is first look at the target and decide is it appropriate for the patient? Because we know, and there's some good TI material again about, we should be adjusting our targets in some older adults. The second is if any of the three medicines have shown no benefit, I would stop it. So one of the things that we can see sometimes is that we sort of start one antihypertensive and it doesn't work, and so we add another one, but we forget to stop this first one that doesn't work. But that's a kind of a side issue. So it's a tricky thing, and it probably depends on the degree of hypertension. So the biggest bang for your buck with treating hypertension is it's a dose response curve. So treating severe hypertension, sort of over 160 systolic for older adults, is where you get the real bang for your buck. Treating to lower than that is really kind of fiddling around the edges a bit more, and there's a good Cochrane review that shows that there's no, clear evidence of benefit to going below those targets. So you can sort of think about those things. But if you really, for all sorts of reasons, need to get the blood pressure down, if it's at a worrying level, then it might be worth, in that case, kind of doing an N=1 trial, but discussing with the patient the uncertainties about the benefits of that and sort of assessing whether they still feel good on the beta blocker or not. So not helpful. We can't give you any certain answer from the expertise in the room. So it's worth thinking about the goals, revisiting the targets, and thinking how high is high? Is it alarmingly high, or have we taken the top off it enough?
Just take a couple of questions from online. So 1D is about the SSRI discontinuation, and they're wondering whether the level of depression plays a part. So this person's concerned about a patient with severe depression and SSRI discontinuation, whereas the evidence mostly apply to mild or moderate depression.
The evidence for what? For stopping?
Discontinuation, yeah.
So for discontinuation, the evidence was for a range of depression that we saw in primary care. So it was the full range of severity that we see, most of which we know is mild to moderate and kind of not hospitalised. But in all of the things that we looked at, we found no predictive factors. So we looked at things like severity, duration, number of episodes, and nothing seemed to predict those who had a recurrence and those who did not. Personally, in my practice, if someone has severe depression, I would tend not to use SSRIs. I would actually use, commonly would use a tricyclic like nortriptyline. I've had great success with that, very few problems. There's some concern about sort of safety and overdose, but that's easy to manage because you only give short-term supplies when you're starting. And I've never had any problems stopping tricyclics as well. So I think they're probably underused, especially in younger adults with severe depression. And the evidence would suggest that they're more effective in severe depression.
Okay. Thank you. And one more question online about stopping the beta blocker post-MI. The question wasn't there some antiarrhythmic indication for the beta blocker, and was the evidence reflecting anything about that?
Yeah, there was, but that was before the kind of acute diagnostic strategies that we have and the acute management, the sort of rapid revascularization and things that are now. And so it's thought that that risk is probably diminished, and that's probably why we're seeing less effect. Yeah. But in fact, those decisions are usually not ours, because those decisions about whether to start in that sort of acute period are made in hospital. So we're really looking at those patients who are already on them, a period of time out.
And someone online was asking about access to slides. So for those of you in the room, there's about 100 people online. All the slides will be made available to everyone here and online, so don't worry about that.
Except the data slides.
Except the data slides, that's correct, yeah. And there's one more, we'll take one more question and we'll move on. Yes, sir.
Yeah, one of the classes that wasn't mentioned was cholinesterase inhibitors. I work in long-term care quite a bit, and it's quite a dilemma to decide when and if to stop cholinesterase inhibitors. So I just wondered what your thoughts might be about that.
They're of fairly modest benefit, and I think they're a great opportunity to stop, especially in moderate to severe dementia. It's very much a sort of patient and family discussion, but I would err on the side of stopping them in general, given the lack of evidence for meaningful benefit for patients. They treat hope more than they treat patients, I think. And there are also, I didn't mention it because we could only use 3 or 4 examples, but there are other drugs in dementia to consider stopping for futility. So, stopping prevention medicines, and there's a great scale by a group in Australia called the MATCH-D, and it offers really sensible suggestions of drugs that we should be stopping in moderate to severe dementia, drugs for prevention, and drugs that are sort of futile, sort of life-prolonging drugs. So, yeah, it's a diagnosis of dementia is a great opportunity, and it's particularly important that we stop SSRIs for depression and dementia, because it's not that there's no evidence of benefit. There actually is evidence of no benefit. So SSRIs are of no benefit for depression in patients who've been diagnosed with dementia. So it's another great deprescribing opportunity. Yeah, so it's a great question.
So with that, I'll thank you again, Dee. That was wonderful. I appreciate it.